everyone, and happy ADHD Awareness Month. I want to start by saying this ADHD Awareness Month special marks our 10th episode in the series. I would like to thank all my subscribers and viewers around the world and all the interviewees that have contributed to this series thus far. I would also like to thank my family who have provided immense support for this series behind the scenes and have provided me the support I need to make it happen. Without all of you, this series would not be possible and would not be successful as it is. Now I would like to introduce our guest with a personal account. When I'm doing these videos, approaching the interviewee is a very grueling and daunting task. But I would like to say that Dr. Elliott is nothing short but incredible. He has provided immense support for children with ADHD throughout their lives, throughout his career, and the support he gave me in making this video possible are very admirable. Dr. Elliott is the reason why I get to continue my advocacy for ADHD, and I cannot thank him enough. So Dr. Elliott, thank you for being on the channel today, and I appreciate it with all my heart.
My pleasure.
Now let's talk about Dr. Elliott's very successful career. His career spans over 4 decades. He received a board certification in child and adolescent psychiatry with extensive clinical and research expertise in ADHD across the lifespan. He was an affiliated clinical professor in the Department of Psychiatry and Behavioral Sciences at Stanford University School of Medicine, where he trained future clinicians. He was a former director of the Children's Center at the Langley Porter Psychiatric Institute, UCSF, leading child and adolescent psychiatry for 17 years. He was also an emeritus clinical professor at the UCSF. He was also a chief psychiatrist and medical director at the Children's Health Council in Palo Alto, a national leader in supporting neurodivergence in youth and families. He was also a co-investigator in the landmark multimodal treatment study of children with ADHD, one of the largest and most influential ADHD clinical trials ever conducted. He was also the author of the book Medicating Young Minds: How to Know if Psychiatric Drugs Will Help or Hurt Your Child. And he was a researcher pioneering objective measurement tools like cognitive testing and eye tracking for ADHD assessment. He has been retired since 2021. So Dr. Elliott, thank you once again, and let's get into our interview. For our first question, ADHD diagnoses have increased over the past few decades. From your perspective and research, do these rising numbers reflect a true increase in ADHD prevalence, or are we just changing how we define and recognize it?
That's a great question. And I'd make a slight correction. Over my career, which goes from the early 80s to 2020, it's both increased and decreased over time. Most of that's been changes in definition, although the other huge change from when I started in the field was the recognition that ADHD didn't magically go away at puberty. When I first started, there was just the beginning of the understanding that ADHD actually could persist into adolescence and even into adulthood. That's certainly been a significant factor in terms of overall numbers, prevalence estimates, because before, if you were after puberty, people just didn't look for it and didn't assume you didn't have it. The low point was actually probably back in about 1990, and that was because there was a decision by the American Psychiatric Association, really quite arbitrary, that they wanted it to be about 3% of the population. And they defined their criteria so that that's what it was. There was no, it was not a scientific decision, it was a political decision. There have been times back in the 60s, for example, and Chad, children and adults with hyperactivity attention disorder, was pushing for a 20% prevalence rate.
Wow.
Uh, Most estimates, I mean, it does fluctuate some, but most estimates is that it's somewhere between 7 and 10%, and that typically it's most commonly and most severely affects people in their um, middle, elementary school and middle school ages, although it certainly can affect individuals in high school as well. And we now know that it can have an impact on adults too.
Yeah, that answer taught me things that I did not know before. The fact that government leaders made ADHD diagnosis more of a political thing rather than a scientific thing. And your answer really I agree with a lot because I did some research on this and implied by sources by Vincer et al. 2014 and Ferron et al. 2021, they all point to this one conclusion that society's increased understanding and knowledge about ADHD is what has contributed the most to increased diagnosis rates. I think that's more of a factor than actual biological increase because, as you said, it increased when doctors actually took the time to understand children and how their environment was, and it significantly decreased when the government made it more of a political matter rather than a scientific matter.
Yeah, it wasn't the government per se, it was actually the American Psychiatric Association. They control what's called the Diagnostic and Statistical Manual, and that they hold it very dear because it ends up being a big money maker for them. But we're now on what's called DSM-5, and that was released in 2013. That's where the 7 to 10% kind of range comes from. The lowest was DSM-4, which was about 1992, if I recall correctly. And one of the issues in the field, which has really not been resolved, is are we talking about a specific disorder? And certainly there are kids where there's no question in my mind that there is a disorder. Many psychologists would like to actually view it as a spectrum, as a no specific cutoff, but there are people who have more attentional or hyperactivity problems and people who don't. And if you look at most of the diagnostic tools, which are developed by psychologists, that's the way they handle it. Your so-called, how many deviations are you from the norm? And if you're way more hyperactive and way more inattentive and way more impulsive, then that would make your diagnosis of ADHD.
Yes, you've published research using cognitive tests and even eye tracking to identify ADHD and predict treatment response. How close are we to using these objective tools in everyday clinical settings?
Not close at all, unfortunately. The there are several approaches that have been trying to do it, but this is still a clinical diagnosis. There are tools. All of them require some level of cooperation, which makes them inherently subject to error because if a person doesn't cooperate with the test, you may get skewed results. But one of the problems and the reason I was interested in this eye tracking approach, which I thought actually might help with diagnosis as well, is that most of the tools that we have available, and we can talk about those if you want, but most of the tools we have available have to be done in a clinical setting. So that's not where people live. And what we really would like to know is what's going on with somebody, particularly with regard to medication, where they live, at home, in school, at play, sports, whatever.
Yeah, so I can see why they are not being allowed to be used because, like, as you said, they're supposed to be used in a clinical setting, and that's not where people live. How do you think they could be, that could be adapted, and how do you think that could be fixed in the future to make them more accessible and used in the clinical setting?
Well, that's a great question. Unfortunately, it involves more research, which is unfortunate. Every researcher will tell you we need more research. But if you haven't gotten that message, you will with other interviewees. In this case, it really is just exactly that. And at the moment, as you're aware, the federal government is not particularly enamored of funding research. So a lot of programs have been cut, um, and I think basically not much is going to happen over the next few years until we get a different administration that hopefully is more interested in research.
Hmm. Yes, that makes sense. Yeah. Diagnosis rates vary dramatically by region and background. What cultural or systemic barriers have you observed that led to under or overdiagnosis of ADHD?
It's a great question. I actually did a study. I'm not sure we ever published it. The Kaiser Mental Health System, at the time I was doing this, had 26 different clinics in the California area, Northern California area, and the diagnostic prevalence varied from 1 to 7%, depending on the clinic. So part of it is how interested is that, I mean, unfortunately, there are still people who don't believe ADHD is a diagnosis, and that includes medical professionals as well as others. Scientology, for example, has had a long-term absolute rejection of ADHD and particularly of stimulants for ADHD. And back when I first started in the field, they used to picket major national meetings claiming we were poisoning our children. Um, the there's there are a number of factors where the diagnosis is more likely, and it some of it may surprise you. So, for example, one area where an increased diagnosis may occur is people who are well-to-do and want their children to do better. And the hope is that if they get diagnosed with ADHD, that they can get somehow they'll attend better and they'll do better. There's very little evidence to support that, but there is a whole movement of so-called cognitive enhancers, and stimulants have been looked at in that regard. And the real answer is that it doesn't actually enhance your IQ. But so you've got that population of I want my kid's doing okay, but I want him or her to do better. There are low socioeconomic areas where
Actually ties in, yeah.
right where they get targeted because there aren't any other services available and they're not behaving. Usually those are the impulsive kids who are disrupting class, and they get sent to a pediatrician who does a 15-minute exam and says, yes, this kid's hyperactive, and gets put on treatment. So there's, I believe you may at some point be interviewing Stephen Henshaw, and he and an economist actually did some beautiful work looking at the economic consequences of diagnosing ADHD and what pressures are for and against it. ADHD is not covered as a disability in the same way that speech and language is, or speech and language problems are or learning disabilities are, it's viewed as it's actually covered under the American Disabilities Act. So if you have ADHD, you can get what are called 504 accommodations, which are basically no cost to the institution. Um, but so there's no real economic advantage from most schools' point of view of diagnosing somebody as ADHD, and there's in most areas. But again, there are regions. And there are even individual psychiatrists. There's actually a pediatrician in the Bay Area who I could guarantee if a family went to take their child into that person, not only would the child come out with an ADHD diagnosis, but both parents would as well. So it's because we don't have an objective test, because we don't have a blood measure or any other kind of real measure that would allow us to objectively say this person has ADHD, it becomes a matter of judgment. And unfortunately, there are lots of pressures for and against that.
Yeah, your answer actually tied back to what we were talking about earlier about how knowledge about ADHD influences diagnosis rates to a very high degree. And also what you said about how the clinician just hands out a 15-minute checkup and then most likely confuses their misbehavior for ADHD actually ties into my next question. Many young people show overlapping traits, anxiety, learning differences, or emotional dysregulation. How do clinicians avoid over seeing these or missing ADHD in these complex cases?
It's a great question, and again, it depends on on which part of a medical profession you're talking about. A good workup for ADHD, just precisely because of what you're talking about, probably involves at a minimum 2 to 3 hours worth of evaluation, cognitive tests, history, um, uh, a sort of a full, how is your day going, a whole variety of things. And part of that is because we do need to separate out these other conditions, which unfortunately may be looking like ADHD or may be there as well as ADHD. So you mentioned the MTA, the multimodal treatment of ADHD. Only a third of the children that we studied in that research project actually had just ADHD. The other 2/3 had at least one, and a few of them had as many as 5 other diagnoses. The most common were anxiety, which is about a third of kids, oppositional defiant disorder, which is about 40% of kids, depression, which was a little less than a quarter of kids, some tic disorders. So one of the complexities is this just a comorbid condition that the child also has, or is somebody who's really anxious going to look like they have ADHD because they're so anxious they can't focus? And part of that is just looking at historically. So anxiety typically comes and goes, whereas ADHD is a pretty constant problem or issue. So if you get somebody who's 12 or 13, has never had any attentional problems previously, but suddenly develops really significant problems with attention, you can be pretty sure that it's not ADHD because you don't catch ADHD at 12 or 14. Now, somebody may have missed it, which is another issue, but if you've got a clear history of third, fourth, fifth grade, everything was fine, there were no issues, and suddenly somebody's having lots of problems focusing, likely it's not ADHD, it's anxiety.
Yeah, that ties actually back to what we were talking about earlier about how not doing just a standard checklist, like a 15-minute halfway done checkup. It should be more focused on like have more context, think more about their life up to that point and how that actually may tie into your judgment about which disorder it is. And that's why clinicians should do like a multi-source approach instead of the standard checklist, because if they have more perspectives of ADHD as a disorder, they'll be able to distinguish it from anxiety and other coexisting disorders the patient may have. So you've
Exactly.
just yeah, so you've described diagnosis as both a science and an art. What qualities make a truly great ADHD clinician? How can parents know if their evaluator is through and evidence-based?
That is really tough, because often they don't have a whole lot of choice. It really depends on the resources that the family has and what they can look for. In general, particularly when one is looking for a new diagnosis, I think going to a well-established ADHD assessment clinic or assessment and treatment clinic is better than just going to your pediatrician. Um, because they're going to be doing all the things that I was just talking about. Um, Unfortunately, even there are, I'm not going to name names, but there are centers that are well known for overdiagnosing ADHD. Um, it's usually word of mouth. I think actually Chad, which I mentioned before, and I'm not pushing it. It's not that I'm a and anyway, I used to be on their advisory board, but I'm not affiliated with them. They've been around a long time, and one of their resort, and they're free to families, and you can access their website. They will often be able to recommend somebody in somebody's area who sort of meets their criteria for doing a good workup. Uh, but um, it, it's mostly psychiatry and psychology. Um, Pediatricians, unfortunately, because particularly they outnumber child psychiatry by a factor of five. Um, Pediatricians often are the first people to touch the child because that's where the connection is, and they've already got the family already has some connection with it. And there are some pediatricians who do take the trouble and time to try to do a diagnosis. But for most kids, the likelihood that a pediatrician is going to be looking for these other kinds of issues is very small. Most pediatricians see at least two patients every 15 minutes. And even if they have a special diagnostic half hour, that's still not enough time to really do the work that needs to get done. Now, once the diagnosis has been made, particularly for relatively simple treatment cases, going back to a pediatrician for treatment may make a lot of sense. But for diagnosis, uh, I would recommend that families, look up an ADHD center that goes through a thorough diagnosis.
Hmm.
Unfortunately,
Yeah.
it's not cheap. It can be as much as like $5,000.
Also,
Um,
yeah, another ideal another ideal thing that a clinician should have, which makes them the best option for the kid, is that they need to have some more uh, uh a sympathetic part to them where they could actually listen to them and how them communicate their feelings, and they also have like, it's like they have like emotional attachment to them where they could tell them it's gonna be okay, you don't have to change who you are, you just have to adapt, you have to you just have to do this differently. You just have to do this differently. Just that reassurance that the clinician should have towards the child is very important.
Yeah, I
If
have two sons, one of whom, our younger son, has inattentive ADHD. He's actually a physician at this point and has three different certifications. Um, but his was mostly inattentive and really didn't become a problem, even though, I mean, he'd lose things and it was, you know, there were signs of it, but it was about 12 or 13 before, which is very common for inattentive ADHD, before it really began to be a problem. Fortunately, what he didn't have, and actually I missed talking about earlier, is executive functioning problems, which sadly the American Psychiatric Association has not yet recognized as an official diagnosis. But these are kids who, um, beyond their ADHD, they just have trouble planning and organizing and getting things done in an efficient fashion. And there are good tests for that. And There actually now there's a whole profession of executive functioning coaches that because we don't have medicines to fix that. That's um, The good news is we've got a lot of tools that we didn't used to have in terms of electronic organizers and those kinds of things. But uh, that's another area that one can look at if you're doing a more extensive testing that just a brief questionnaire is not going to handle.
yes, and for our final question, after years in this field, how has your understanding of what counts as normal attention or behavior evolved? Are we moving toward a more neurodiversity informed understanding?
Well, there's certainly. I actually was asked to write a chapter about the advantages of ADHD for young kids, and was unable to do it. I have a colleague who likes to say that if you wanted to create an environment that is the most difficult and likely to produce the most symptoms for someone with ADHD, you'd be hard pressed to come up with something better than schools. It's boring, it's repetitious, you have to sit quietly for long periods of time. You have to study things that you don't care about. Um, um, so um, it's hard to think of ADHD as a strength in that regard, but certainly as you get to your age and as you get into adulthood, ADHD can be a real advantage. Silicon Valley, for example, has a number of people who are um, have, as adults have pretty significant ADHD, and the advantage for them is that they can multitask. They're okay with doing 5 or 6 different projects simultaneously, and in fact, it helps them. In medicine, a lot of individuals with ADHD go into emergency psychiatry because the emergency room keeps them interested and they're sort of constantly stimulated. Um, there are there's a book called The ADHD Advantage that I'm not a huge fan of, but talks about the number of very successful individuals who have ADHD and feel that it really helps them become more inventive and more productive, but also realize they have to be on medication part of the time because um, they don't actually accomplish much if they're not on medication. So they take holidays, sometimes like 2 or 3 days a week, where they can come up with new ideas and feel more creative. But then they take treatment medications during the rest of the time so that they can actually organize themselves, look through the list of ideas they had, decide which ones are the most likely to succeed, and move from there.
That was an amazing answer, Dr. Elliott. I feel like as society has evolved, there has been a change in understanding. Like the word deficit has been turned to like difference. And I feel that many individuals with ADHD need to hear this. There's a difference between the words different and inferior. Just because you are different does not mean you are inferior. When you are different, that means you just have to learn different. You have to exercise different. You just have to grow different. If anything, having ADHD just makes you more unique, and you develop your own style and your own unique journey to success. And the parts of ADHD that can be negative, you could turn it into your own advantage as well. Thank you, Dr. Wright, for your candid answers. I would appreciate if you all could like and subscribe. And as always, I like to end my podcast episodes with a powerful quote. Today's quote is from Thomas Edison, and it reminds me to always keep a growth mindset and to always uphold perseverance. Quote, I will not say that I failed 1,000 times. I will say that I found 1,000 ways that don't work. End quote. What Edison meant by this quote is that he did not perceive his mistakes as failures. He perceived them as a way of, okay, this method does not work. Let's try another method. If that doesn't work, let's try another one until it works. We could actually implement this into our lives for anyone who has ADHD, or if you don't have ADHD, anyone can implement this. If you are trying a certain method to succeed and it's not working, try another way until it finally sticks and it works. Thank you all for reaching the end of this video. I would appreciate if you all could subscribe and stay tuned for our part 2 later on about what to do after you officially get diagnosed. Happy ADHD Awareness Month.